Okay, we'll get started now. Welcome, everybody. I'm Chuck Friedman. I'm the chair of the Learning Health Sciences Department at the University of Michigan Medical School, and I will be introducing both the session itself and our speaker today. So today's topic will be accelerating Europe's data landscape for learning health systems. Our speaker is Dr. Dipak Kalra, who I will introduce in just a moment. Next slide, please. So just to talk a little bit about how things will work. First of all, this session is being recorded. There are always people who would like to attend these sessions, but are unable to in real time, and we record these sessions so they can partake of the wisdom that is being conveyed. So the link will be shared with all attendees and registrants. We are going to use the Q&A button that you all have on your screen to record your questions, and when the time comes, address them to Dr. Kalra. I believe he's planning on pausing at a few points during his presentation. So if you have a question pertinent to something that has recently been said, please enter it right away so we can put that question to him at the time that he pauses in close proximity to when your question was generated. Next slide, please. So in more detail, we have with us Dr. Dipak Kalra. He's a clinical professor of health informatics and director of the Center for Health Informatics and Multi-Professional Education, acronym CHIME, at University College London. And he's also president of the European Institute for Health Records. He's a director of the Open EHR Foundation and a fellow of the British Computer Society. And as he often says, in an earlier phase in his life, he was a general practitioner in London. I know Dipak very, very well, and always find him engaging and knowledgeable and insightful, and I'm sure this presentation will be no exception to that. Many people I know from the UK, because of their accent and the way that affects us over here on our side of the pond, they always sound right. But I will tell you that in addition to sounding right, Dipak usually is right. And with that introduction, Dipak, I will turn things over to you. We're really looking forward to your presentation. And please, if there are some details about your background that I have failed to mention that are pertinent, please add that to your self-introduction. Okay.
Thank you very much, Chuck. I think that the thing I will say is I don't think I am always right. So maybe that's the only piece of your introduction I would question. But maybe the audience can also challenge me on occasion.
Dipak, I said usually. I said usually.
Oh, usually. Okay, then you win. You win. Okay. So thank you very much for inviting me to address the Collaboratory and to really tell you a bit about how we are hoping to see an acceleration of the capability in Europe for learning health systems. And I will be speaking today very much from a European perspective. How do I see things in Europe? And I will just also give you a little bit of a one-slide background of the institute that I'm nowadays part of and co-created several years ago, the European Institute for Innovation Through Health Data. And this is in a way my credentials now. It's almost my disclaimer, but it's not really a disclaimer. It's a neutral, not-for-profit institute which brings stakeholders together with an ambition to co-create solutions so that we can capture and share better quality health data and then make better use of it in trustworthy ways for smarter healthcare and efficient research. And to some extent, I would say that is a long-winded way of referring to the learning health system, that there is data and that you learn from data and you end up with smarter healthcare and more efficient research. You can see on the circle the kind of stakeholders we bring together, and we feel that in spirit, and I wonder if you will identify with that, that the easy challenges around health data have largely been solved. The ones that single stakeholders can address on their own have been done. And the only ones that are left now are the hard ones. And the hard ones require stakeholders to come together and co-create the way forward, because they're out of the grip of any one stakeholder alone. And that's almost the philosophy with which we work. Now, I'd like to jump into the subject matter with an example. And I have on this slide the example of heart failure. And what you will see is that there are three charts. One is referring to variation in death during a first heart failure admission. The second one deals with 12-week mortality rates. And the third one is readmission rates for heart failure. And what I want you to notice on this slide is that there are on the vertical a bunch of countries, almost all of them European countries, and then there are orange bars that tell you about that variation. And the important thing to take on board is that there is between a 3 and 4.5 variation between European countries. And also the countries are not always in the same order. If you were to take as an example Sweden, it scores rather well on the first chart and is put pretty much in the middle on the second and quite low on the third. And that's what you see for the countries, that they vary in where they are. So what do we take from this? What we can take from this is that across Europe, there are places where heart failure care is delivering good patient safety and good health outcomes against these indicators. And in other places, it's not. And the question that has to be asked is why? What are the differences? And how can we enable everybody, I'll say in Europe, but actually the planet would be fine, to experience the best possible heart failure outcomes? And that is an example, a small example of why we need to learn from our data, because without learning from our data, we will not discover which practices are proving to be the most successful from a patient perspective. Now, what we do already know is that if we take patients with heart failure and equip them with home monitoring devices, and we remotely telemonitor them, the evidence is overwhelming that shows that we can actually improve cardiac function, reduce heart failure severity, improve well-being, quality of life, and reduce hospitalizations. And I would particularly like to emphasize this, the last line on this slide, improve survival rates. That means we actually save people's lives by giving them telemonitoring. And that's a very important message to convey, because telemonitoring and other things have grown. And there is a risk that patients will think that this is an excuse to avoid troubling the doctor, that we're giving them toys to play with to keep them away. Whereas actually what we're doing is giving them equipment that enables them to have better health outcomes. Now, if you take another example, again, sticking with heart failure, the Liverpool Heart and Chest Hospital in the UK has also done some pioneering work on home monitoring on its patients who are on the waiting list for cardiac surgery. Those patients, those on the waiting list, record blood pressure, oxygen, and diabetes if relevant, and symptoms. And what happens is that a daily dashboard is reviewed by specialist nurses. And what do we find? What we find is that the patients whose readings are stable are reassured while they're on the waiting list. They may not like being on the waiting list, but at least they know they're not getting worse while they're waiting. But if the readings suggest an escalation is needed, they can either have a treatment escalation or they can be brought forward on the waiting list for more urgent surgery. And the outcome already demonstrated, apart from patient satisfaction, which is very high, is reduced emergency hospital admissions of the waiting list patients. So this is about improving patient outcome and almost certainly reducing costs. In fact, if we were to take a look at what has happened during the COVID pandemic, what we see is that remote monitoring and telemedicine services have grown hugely. In fact, according to this data from McKinsey and Company, 38-fold. We had a massive spike at the beginning of COVID, but what we then have had, and I know this only goes up to 2021, is a plateau that is so much higher than pre-COVID. And what that tells you is that we are finding value from engaging patients remotely. And in case you're able to read the small print at the bottom of the chart, it actually lists a very long list of disease specialties that are using telemedicine services. This is not about COVID remote monitoring. This is about remote monitoring and telemedicine across a wide range of specialties. And there is a prediction now that over the next few years, that market for telemedical services and digital therapeutics will grow hugely. Now, are we in danger of pushing things onto patients they don't really want? Well, when we engage with patients in focus groups, in surveys, in discussions and interviews and all sorts of other things, what we find is that actually patients are mostly really enthusiastic to use technology, digital innovations for a diversity of purposes to do with managing their own healthcare, preventing illness, being a bit more in control of their own disease, tracking how they're doing, monitoring their symptoms, even if they can, fine-tuning their doses of drugs so that they get optimal care. And if we speak to patients in the right way and give them the genuine assurances that we can offer about how data are safeguarded, we find that patients are actually also quite enthusiastic about co-creating knowledge, allowing their own collected data to be used for research, and allowing the clinical data held in electronic health records to be used for research. So what we find now is that there is a growing opportunity to collect data from people, and as part of their healthcare, whether it's prevention or treatment monitoring, and also a growing opportunity to use that data for research. And when we speak to research organizations, they are enthusiastic to have access to this new channel and new source of data that has previously eluded them or been only available in very poor quality, patchy environments. So I'd like to tell you about a European project, a very large-scale European project that is one of a number of those that we run in Europe, which are public-private partnerships. And that is where the pharma industry, a dozen or so pharma companies, come together in a pre-competitive way alongside academic partners, smaller industries, and also healthcare organizations like hospitals to try to tackle challenges. And in this case, the challenge to be tackled is how can we scale up patient engagement in collecting health outcomes? So the H2O project is basically establishing a set of not-for-profit observatories, we call them. And in the research phase, there will be an Austrian one, a German one, the Netherlands, a Dutch one, and a Spanish one. And these 4 centers will collect data on 3 disease areas: diabetes, inflammatory bowel disease and cancer, breast cancer and lung cancer in particular, from patients, and bring that into an environment where it can serve value to a number of different actors. So in these scenarios, completely not-for-profit and with robust data protection, patients will collect outcomes data on apps and electronic health records will be tapped to pull out outcomes influencing health-related data and fuse this together at the observatory level so that we have insights on the outcomes and the care pathway actions that generated those outcomes. Now, who will benefit from that? Well, first of all, we're saying to patients, you can benefit from this. And one of the benefits we're offering patients is the ability for them to be able to see how their outcomes are compared to anonymized aggregate patients like them. So when we have enough patients, we will profile the patients and pool the outcomes data so a person can see that at this stage in my health situation, patients in my position have similar outcomes to me, or they're heaps better than me. Something's not right. We hope that with the clinicians also seeing this, we will enable meaningful outcomes-oriented conversations between patients and their clinicians so that we actually help to make the clinical discourse more rich and meaningful. And then, of course, health systems are really anxious to know about outcomes, for example, to promote value-based models of care in the future. Regulators and HTA, health technology agencies, are keen to learn more about outcomes and treatment effectiveness, and then research. Academic research and industry researchers are also very keen to learn about this. Now, what do I mean by patients collecting outcomes? We did, for all of the disease areas, we have conducted a Delphi study with a high proportion of patients to find out what are the data items that are likely to be useful at helping to give insights from outcomes. And I'm not going to go through all of them, the 101 variables here just for one condition. But what we are doing is now getting those through into ICHOM, the International Collaboration on Health Outcome Measures, and this data item inventory standard set is actually already on their website. And we are looking to work with ICHOM so that we develop empirical experience of the outcome measures that are proving most meaningful and useful for clinicians, for patients, and for research, so that we can help, hopefully, eventually, to propagate these internationally. So I've told you already what I think some of the benefits are, but really what we want to do is to make sure that all of these different stakeholders get value. We have to become a sustainable network of observatories. We want more than 4, and we want more than 3 diseases in the end. And so we're very much hoping that in the coming couple of years, we will go live and then demonstrate that those stakeholders with budgets, that is the bottom 2 probably, would actually be willing to pay for access to data, either through a membership fee or by paying for particular research studies. And this would enable the ecosystem to survive financially as a not-for-profit business. Now, that's just one example, but really what we are trying to promote in Europe right now, and I suspect this is identical to what you're trying to do everywhere else, is to really point out how health data can deliver value and must deliver value for the benefit of all. And so we are very keen to emphasize that health data, when collected well in structured, coded, processable forms through good quality electronic health records that have decision support and algorithms and other kinds of computable knowledge embedded, really deliver benefit to patients. I'm not going to read all the bullets out. I'm sure you can read them, and I'm sure you can identify with them, but many, many ways in which individual patient care can benefit. And then a whole series of things at population level that health systems need to grip. So things like pharmacovigilance, patient safety, early detection of adverse events with drugs, public health surveillance and public health strategy. Who of you needs to be reminded that we were desperate for public health intelligence at the beginning of COVID, and we were really all globally caught out with inadequate methods of rapidly gaining the insights we needed. We have to make sure in the future we're better equipped to cope with the next catastrophe. And there are other things that I've listed here. And then when you go to a bigger scale, what you might call big health data, we don't only need to understand diseases and help stratify patients, we need to accelerate drug development, personalized medicine, diagnostics, devices, AI, and so on. So the landscape of opportunity for data is huge. And I really feel now we are at the stage in Europe where we are starting to invest. And I'm going to just put this slide up and then pause for a few moments. What we are doing in Europe is using sometimes European Commission funding, sometimes national funding to develop infrastructures, often health infrastructures, sometimes research infrastructures that bring together data sources and allow for a scaling up of analysis and insight generation. And we see really an excitement now that in Europe, the capability for us to be able to learn rapidly and to learn on subpopulations rather than only broadly assembled populations is going to be very powerful. So there is an excitement energy at the moment in Europe. And I would like to just pause and really ask, I mean, I'm wondering if I'm speaking here to the converted, if you are all saying to yourselves, yes, we know this, we are excited too, we are in the middle of massive investments in infrastructures and capabilities, and we are all eagerly looking forward to the opportunity to analyze at scale, learn more, and deliver better healthcare and accelerate research. So is Europe an outlier, or are you there with us? I'll just pause and see, Chuck, have you got anything yet posted?
Oh, yeah, we have two questions.
Okay.
So one is actually one that I was thinking about myself. Patients like me, in quotes, sounds like
yes.
a very challenging task. How far along is the H2O study in getting this implemented and tested to work? And do you have metrics for this?
So the simple answer is no. We are at a stage in the project where we're just about to launch go live pilots to start collecting the data. We've been designing and building the ecosystem up to now. So I think the answer is almost say, ask me in a year when we start to do that. But I think the questioner has also put a finger on a very difficult challenge, which is how many people do you need to have profiled in order to determine which patients are like me? And here, you know, if we had millions, we would be able to find people with relatively fine-grained characteristics that resemble an individual. If we had only 10 people in a database with diabetes, then we really can't do much about subdividing the 10 and saying, well, you're like these 5 rather than those 5, and this is meaningful to give you. The numbers aren't enough. But I hope that the questioner has in mind actually that the real answer is we don't know. And the reason we don't know is we've hardly done this before. And what we expect to do is to learn as people start to see comparative outcomes. What are the nuances of an individual that makes them feel that they can identify with an anonymous community that they feel is like them enough for them to make valid inferences on the outcomes? My feeling is that we are enabling a massive area of new research. H2O will never have the resources to do all of that. And I therefore hope we open the door on global research collaborations to answer the question that your very smart questioner has put.
Okay, we have another smart questioner
okay.
who asked, how do you prioritize prevention versus chronic disease monitoring in this system of observatories?
Well, for the moment, we have not prioritized prevention. So people have a condition and then we monitor them. Now, you could say still, I've ducked the question of secondary prevention. So as we recruit, we will discover there are people for whom better quality care leads to the avoidance or the delay of secondary complications. for example, in diabetes, delaying the onset of kidney disease, or delaying the onset of peripheral vascular disease. Again, rather like the previous question, it's too early for us to see. We are temporarily hampered by the fact that we are going to need to recruit people who are digitally literate, because we don't have a budget to really educate people well enough who might be infirm or vulnerable groups, underserved populations. We're not able to recruit children at this stage, although we would have liked to with diabetes. So to some extent, we are going to pick perhaps not the most needy patients, but we're going to have to pick a pragmatic set of patients that we can do a proof of concept on. But we are desperate to get into those other underserved or highly vulnerable or high-risk patient groups, because they will potentially benefit most from this solution. There are all sorts of difficulties around doing informed consent, educating people, bringing on them board, bringing on caregivers if they need caregiver support, that mean it becomes quite difficult when you're doing something brand new to do something complicated at the same time. But we would love to get there.
Thank you. We have, I think we'll take two more questions that have come in. The next one goes to the burden on physicians of sharing this quantity of data. To what extent is this a burden, and is it an acceptable burden?
Well, I'll put it another way. It's a critical success factor that it isn't. Because if we said to clinicians, the data that the observatories will collect requires you to do anything active to enable the data availability, that I think would just be killed at first base. We have to extract the data with consent, with permission, from electronic health records, from already routinely captured data, as good and bad as it is, and we know it's good and bad out there in the real world. So we can't do that. Now we have a different question, which is when patients are equipped with outcomes, when clinicians have a dashboard that contains patient-collected outcomes as well as their routine data, and the patient comes in the consulting room and sees them, will they feel that they are now burdened by looking at more data? And that is something we have to study very carefully. When we speak to clinicians, they on the one side recognize the possibility that they will have to have slightly richer and deeper conversations with their patients, because there's more data to discuss and more thinking to be done together, potentially more clinical care pathway co-creation. But on the other hand, what they're hoping is the workload will reduce because patients are more in the know. There is less basic explanation required. Patients will have a better understanding of their position. And so there is a real trade-off possibility that certain things will take more time and certain things will take less time. The feasibility studies will be running from the next couple of months. For some months, will give us initial prototyping insight into that trade-off. And is it more, is it less? However, I think what I would say is that patients are, not every single one, but the higher proportion of patients are using the internet to understand their condition. They are wanting to be more involved in decision-making. So the tide is already there. I hope that what we are doing is not making the workload any worse than it would be naturally, but providing a structured and organized method for managing that tide of patient energy.
Okay, Dipak, thank you. We'll take one more question and then we'll move on. And we have more questions than that. And I will say
you'll need to watch time then, I think.
Yes, and we'll take those at the end, time allowing. Okay. In the US, routine real-world data is often recorded using different data definitions and terminology than research data in clinical trials. If the same gap exists in Europe, how do you overcome it?
Well, what that questioner is noting is absolutely right, and it's not a US phenomenon, it's a global phenomenon. Clinical trials operate through protocols where not only is patient care pathway formally and meticulously specified, but data documentation is meticulously specified. Real world data doesn't behave like that. And there is therefore always a slight messiness to real world data. There are inconsistencies in the way things are recorded and how they're recorded, even what is recorded. Tremendous variability, for example, in the recording of negative findings. Some clinicians are meticulous, others don't bother to record things that weren't there. However, real world data, despite being messy, has on its side two very important characteristics. One is scale. When there are millions of data points to examine, you can start to statistically correct for the messiness. And the second thing is, it's real. Whether you like it or not, randomized controlled clinical trials, such as those run by the pharma industry, use patients that have the least amount of variability between them. And the drawback, which we all know and regulators know, is they are not always typically representative of the real patients who will take the approved medicine downstream. So in fact, real world data has the benefit that it's real. And messy or not, actually there are learnings from this data that we have to make the effort to make as valid as we can, because that is realistic learning. So I think the questioner is right. We don't have a choice. What we have to do is partially to use tools and things like data quality assessment to get the best we can out of what we have. And we need to encourage health systems to invest in their data, including in their data collection.
Okay, thank you, Dipak. Well, so we can
move on.
And we'll try to get to the other questions at the very end.
Okay, all right. So what I'm actually going to do, just to save a little time, because I think this has taken a little bit longer than I thought, is I will just pause here with another, this slide, with another example here. And this is the European Medicines Agency. So this is really actually addressing the last question. The European Medicines Agency, which normally lives in the universe of randomized controlled clinical trial evidence, usually from pharma, but also from medtech and tech, is now ready and realizing that they need to generate evidence from real world data. And the Darwin EU project, just really starting, is a massive project to scale up a network of centers across Europe that will enable the EMA, the European Medicines Agency, to perform real-world data studies and generate real-world evidence. And I'm going to go straight to an example of a project, another public-private project in which I'm lucky to be involved, called Conception. And this is building an ecosystem dealing with the safety of medicines in pregnancy and breastfeeding. Why is this important? It's because in pregnancy and breastfeeding, it's usually very difficult ethically to randomize women to take a drug or not a drug, or take a brand new drug versus not. The ethics are just really complicated. And so RCT evidence is very limited in pregnancy and breastfeeding. And many drugs that are very promising on the market come out with an authorization label that does not include an assertion that it can be taken in pregnancy or during breastfeeding. So we have a real problem that women who are either planning to get pregnant or are pregnant or breastfeeding have a real dilemma, as do their clinicians, about what to use, what to take. And yet the truth is pregnant women do take medicines. So in the real world, pregnant women take medicines for other conditions that they've got. And so there is an opportunity to learn from that. And so it's nuts that we don't look at what pregnant women actually do take and what happens to them in pregnancy and what happens to their babies. Messy or not, real world data is the only choice we have. And so the Conception project is establishing a pipeline, a data flow pipeline with quality processes and analytic steps on the way, including data harmonization, data quality management, so that it is possible to detect safety signals in the real world data of pregnant and breastfeeding women. And the EMA, the European Medicines Agency, is a partner in this project deliberately because it wants to be on the inside of the learning we make during this project. So there's an absolute example of why real world evidence has to be treated seriously, whether or not we would have preferred the pristine and squeaky clean nature of RCT evidence. So now I want to come to the biggest excitement of all, which is called the European Health Data Space. The European Commission has set itself an ambition to establish things called data spaces, and I'll explain what it is in a moment. But they are planning a number of data spaces in different industry sectors. Health is one, agriculture, transport, energy, and a few others. And we are very surprised. Health is surprised that the Commission has decided, out of all of those glamorous data spaces it could choose, they've decided to start with health. We are normally left to the back of the queue, but health is the first data space that is going to go live. And there is now, in the middle of the European Parliament debates before it's passed, a draft regulation on establishing a European health data space, which sets out the rules whereby effectively, my nickname is a superhighway, a health data superhighway at a European scale that can be used for a number of purposes. And so I want like now just to summarize the EHDS regulation in a few slides, just so you get a feeling for what is envisaged. Firstly, to say that there are two big families of use case for health data at a European level that are being taken forward. The green part of my diagram is focusing on the primary use, that is the use of data about individuals for their own health, their care, and their wellness. And the blue zone of my diagram is about the secondary use of data, that is the use of data for research and strategy, whether it's public health or health system strategy. So you could say the learning is mostly going to be in the blue zone. But let's first of all look at the green zone. So the green zone is going to require in the future that health data that is going to be shared at a European level has to be quality checked and it has to be interoperable. There is a European specification called the European Electronic Health Record Exchange Format, which is to be used as a mandated way of representing data. And this actually aligns very well with international standards. And indeed, it isn't yet, but it will evolve to adopt the international patient standard, which is presently being finalized between HL7 and ISO. Patient is at the center of the green zone. So patients must expect in the future that their health data is consolidated. That means the countries in Europe are under some pressure to bring together the disparate data that a person might have in one or more hospitals, one or more primary care centers. And so you must bring it together. It must be free for the patient to access. They must be able to write in their own record, to record their own findings and observations in their record, and they must have portability. They must be able to take that data to another provider if they wish to change for any reason without any penalty or cost. Countries have to establish national contact points who will help with the cross-border communications. Electronic health record systems will, with a time lag of a few years, have to all be certified. There will be voluntary certification of apps, and the European superhighway for health data that is identified for the individual is called My Health at EU. And also, individuals will be given significant rights to have a say in who is allowed to access their identifiable data. My guess is this is primarily going to occur at a European level. It won't suddenly impose on a country that patients must suddenly be given the right to decide which doctors can see what inside a health system. So this is about cross-border flows. Then when we come to the secondary use of data, any data set that is made available on the European superhighway must be quality labeled, and there is a project about to start, we hope, later this year to define a standard quality label. Fair metadata must be applied, and the European Commission will establish data catalogues so it's possible for people wanting to use data to discover which data sources there exist which might be relevant to them. They prescribe a set of purposes for which data can be used and not used, and I'll come to that. The fees for data access must be proportionate to the cost of making the data available, and they are to be applied equally across public and private data users. The only exceptions are that public bodies that are governmental public bodies should have a discount because of their state responsibilities. But there is no permission for profiteering on the data, and you cannot charge, for example, a company a substantially higher amount than you would charge a university to access the same data. They predominantly expect data to be anonymized, but where you have ethics approval or IRB approval, as you would say, for a particular case for linkage, then you may be able to get permission to use pseudonymized data. There will be newly appointed bodies, one per country, to oversee the provision of data sets. These bodies will mostly place the data to be made available in audited safe havens. So this model is not so strongly supporting federated distributed querying, which is growing as an alternative model for data access. We need to see how that pans out. And there is a requirement for the data access bodies to be transparent to the public about what decisions they've made and what accesses they've granted. So we see this as an absolutely fascinating opportunity space for Europe. There are billions of euros, which is not that different to billions of dollars, allocated to achieving this objective. Now, I will say, I said to you that there are permitted purposes and not. So the European Health Data Space Regulation gives a certain set of purposes for which the blue zone, the secondary data, can be used. So purposes that are in the public interest in relation to public and occupational health, like the bullets that you can see there, supporting public body mandates like medicines regulators who may need access to data, the generation of statistics relating to health and care, which is really a lot about learning health systems and value-based care, education or teaching, scientific research relating to products and service innovation, such as new medicines and devices, the training, testing, evaluation of algorithms, and providing personalized healthcare, which often is quite closely coupled to research. And then there are prohibited purposes, developing any products or services that may harm individuals or societies, decisions, using data to enable decisions to be made with a legal or equivalent weight that might be detrimental to an individual. And as a specific example, that might alter their benefits of insurance or modify their contributions. So you can't use the data really to penalize people in any way or to place them in disadvantage. You can't use data to generate knowledge that allows you to be more skillful at targeting advertising or marketing towards health professionals. And you're also not permitted to treat your access to data as an ability to start cascading it out to others. So these are the purposes and the prohibited purposes. And of course, the Commission hopes that this will help to win confidence in the European health data space amongst the public and amongst all sorts of other agencies. Chuck, I was thinking of having another pause at this point just to get reactions to people about how they feel about these purposes, but other the vision of the European health data space. Would you like me to do that, or do you want me to press on with another 10 or so slides and
sure.
then stop definitively?
No, sure. Let's, I don't know, we could put that question out there. We have capability to unmute participants, right, Kathy?
Yes, we do.
Okay.
I mean, I should just say, Chuck, that, although I have more slides, I don't have to finish them if it turns out that the participants are just so energetic that they just want to keep throwing questions, because they can control the agenda, and I can just summarize the last slides in 60 seconds at the end or something.
Oh, okay. Well, I think this is
let's see how we go.
It's generating a lot of interest. Why don't you put that question to the audience out there, and we can ask people to unmute themselves and respond.
Okay. I mean, I will have to ask you or Kathy to look after the unmuting part, because I can, because I'm still screen sharing, I can't really see too much of the Zoom windows. But what I would then maybe put to everyone in the virtual audience is this. You've heard me describe European vision for both a patient-centric superhighway and a data set superhighway for research and public health purposes, with some caveats, but also here on your screen, the things that the Commission believes in green, public support would exist and multi-stakeholder support would exist, and things in red that they believe they should be categorical in excluding, a public declaration that your data will never be used for these purposes in order to create assurance. Do you think this helps to create assurance? Not enough on its own, but does this sort of stuff help?
Okay, so please raise your hand if you'd like to unmute and comment.
There was a situation that came up in America yesterday where Vanderbilt University gave the patient records of transgender patients to the courts because of a lawsuit examining how insurance was or was not paying the bills for those patients. And this is getting quite a lot of attention here. Yes. It sounds like the system you're creating would prevent exactly that sort of situation from arising.
Well, yes and no, I would say. I mean, on the one side, if by releasing that data, they have exposed those individuals to risk, either risk of prejudice or harm, because they now become known as individuals to have been transgender or to be transgender, or if the insurance sector is able to utilize that data as part of court disclosures to then introduce discriminations, even if they hadn't before, then that would absolutely fall in the red zone. But if in fact, the way Vanderbilt did it, and I have no knowledge of that, was to enable analytics to be performed on, let's hope, anonymized data sets, small numbers of data items. You don't need large amounts of data. Small amounts of data on individuals robustly anonymized to query and determine whether there was a bias. That could have been considered scientific research, even though it was handled through a court disclosure process. To me, it really depends on what was disclosed, the nature of the data that was disclosed, and also the motivation for disclosure and what limits and constraints exist on the data once it's been disclosed. So I don't have any of that information, but it sounds like a hard case. And certainly I would have expected that any disclosure of that kind would be accompanied by a transparency public declaration to say, you will discover in the news, we are telling you now that we have only disclosed this data, we've checked it carefully, we've performed statistical disclosure controls, we've applied privacy enhancing techniques, and we've effectively provided statistical only data for this one purpose. And the data recipient is under contract to only use the data for this purpose. And I think if that had been made public, and I don't know if it has been, it might do something to reassure. Unfortunately, most of the scandals I've heard about of this kind have not been accompanied by public statements. They've been accompanied by news sensationalist reporting, which, well, maybe not sensationalist, maybe accurate reporting. Do you want to say any more about what was done and how this was explained? Or is it all still unexplained?
I dropped a link to the first news report in the Q&A.
Okay.
I originally discovered it, however, from patients on Twitter posting screenshots of the notification they received that their data had been released.
Oh, so identifiable data then. So if people are getting that, it means there's a bunch of individuals who know whose data was released.
Yes, yes.
And if that disclosure to the patients wasn't made in a secure way, then effectively you're revealing that people are transgender through that disclosure. Is that right?
It looked as if they were getting the notice either through the patient portal or by email from the screenshots. I don't know, of course.
Right.
Yeah.
Yeah, well, that doesn't fill me with reassurance, I confess.
So,
but I can't officially comment because there's so much richness that might exist behind the scenes that I don't know. But from what you're saying, it sounds worrisome.
So Brian Martin has raised his hand and is invited.
Okay.
Brian?
Hi, Dipak. A couple of points. Several years ago, the Wall Street Journal broke a story saying that Ascension Health had released about 50 million patient records, including identifiers, to Google. And they had done so without notification or consent of either the patients or physicians. So it appears that the prohibited purposes would help to block that sort of activity. Second point, go ahead.
Yeah. Well, firstly, absolutely. But secondly, don't forget, I mentioned that pseudonymized data, so with the linkage that you referred to, Brian, would have to have ethics committee approval.
Mm-hmm. Absolutely. And frankly, there's something called a safe harbor within our HIPAA that have allowed that to happen. So there's some policy changes that perhaps need to happen in the US to align us with the EU. The second case, though, where what you're proposing or what the EU has proposed would really support research with indigenous populations, is there is something called a data sovereignty movement in American Indian, Alaska Native, and in fact in Māori populations, where those individuals do not want to share their data. They want to have absolute control over it and decide who can access it and who can do research with it. And it does seem as if the proposal you're forwarding or discussing here would help to support these data sovereignty movements. Over.
Well, I think it's interesting you've raised that, Brian, because in fact, there is at the moment a big debate in the European Parliament about opt-out. And to what extent can opt-out be provided at a European scale? And that is a dilemma. It's really a dilemma. No easy answer. So what you described about data sovereignty is that an individual could say, I'm not actually keen that my data is used for drug development research. And the benefit of that is they have some rights, they have some sovereignty over their data. The drawback of that is in order to make informed decision-making, as opposed to knee-jerk reaction decision-making, there is a massive population education program needed, because otherwise most people barely understand how health data can be used and what's useful, and also how it can be safeguarded. Obviously, the Google story you just revealed may or may not include safeguarding of the data. It doesn't sound optimistic, though. But in general, a lot of uses of data that are used for research by both public and private sectors is done by very honest, good people who actually do take care of the data. But the public don't know that, they don't really understand it. And so the risk with an opt-out type situation is that we will actually end up with unrepresentative patient populations, and the underserved communities will then be even more underrepresented in data than they might be today. And we risk then that our research, our decision-making, our care pathways, our AI algorithms in the future are less accurate or less suitable for those patients. And that is a real dilemma. Do you take away people's rights to opt out and include them so that they are properly represented in data sets? Or do you allow them the opt-out and risk that they're not represented in data. I mean, that, Chuck, if I'm honest with you, would be its own 90-minute debate. And I dare, you might have to veto that topic because it's so hot, so complicated. But I would say at the moment, Europe is in a complete stew about how to find the right balance there. And I think it's rightly in a mess because it's difficult to get this right. And I think if people go through pain and suffering and racking of hands to try and figure out the best way, it means they're putting in effort to try to find a good solution. And that's worth having.
So
I do agree with you. Sorry, Chuck.
So you agree with me?
Yeah, what I've heard from those discussions with the data sovereignty groups is that their movement is a knee-jerk reaction to the perceived lack of control of their healthcare data. So I think the solution proposing would help to address that. Over.
Okay, thanks.
Okay, thank you, folks, for putting those comments before the group. Dipak, would you like to proceed at this point with some more?
Yeah, I could do a few more slides.
Okay.
Yeah, just a few more things. Yeah, okay, I will. So firstly, to say that I mentioned the European Electronic Health Record Exchange format and saying that the International Patient Summary which is still a draft, but it's close, is likely to be at the heart of it. At the moment, the electronic exchange format specifies the European Patient Summary, which is about 85% aligned with the forthcoming international one, plus labs, plus radiology, plus prescriptions and so on, plus hospital discharge reports. So there's quite a bit of data that will be in this thing. And we see, even though it's not a comprehensive electronic health record, people like myself who've been trying to work on comprehensive EHRs for decades say we should grab this opportunity. We shouldn't complain that everything is here. Let's get the low-hanging fruit moving around Europe. Let's get everybody learning from it and sharing from it and making patient care safer, because it's more practical to get on with this than to dream of doing the perfect EHR for the moment. But we do have another problem, and it was hinted at earlier, which is data quality. So this is just a splash screen of news articles. I'm not going to speak through them, but there are plenty of stories, both in the academic literature and in the popular press, of times where erroneous clinical data has either led to a patient-specific problem, mistreatment or complication, an avoidable complication, or it's led to a bigger strategic misdecision because people have been misled by data without understanding systematic errors and biases in it. And so we've been working quite a lot in our institute, studying the literature and working with stakeholders on what does data quality mean, and we've identified a set of data quality indicators. Some of you who know about data quality will recognize these. Some of these are well promoted in the literature already. Literature, by the way, from all parts of the world. People have been active in this area. And what we want to try and do is to turn data quality assessment into a feedback loop. So Chuck, your lovely circle of the learning health system, we would quite like at some point to create an inner circle of learning about your data, and not about learning the clinical knowledge from your data, but learning about the strengths and weaknesses of your data. And can you turn your insights into your data quality into actionable change to improve your data quality? And this is actually not a real dashboard that we can deliver today, but actually the statistical methods that would be able to generate it are all there. We just haven't got in a position to be able to assemble it into a dashboard like this and to work with pilot hospitals to present it to them, but we would like to try and do that and to see how data quality can be improved. Some of that may be about systems. The EHR systems may not be facilitating good clinical data capture at the point of care. This could be to do with clinician training. It can be to do with motivation and culture, making data quality matter to the people who put the effort in so that they actually feel a sense of reward from putting in high quality data. And all sorts of other systematic issues can arise. We held an amazing conference last November, where we actually brought together, I think, about 120, 130 people in person, plus a similar number online, only on the topic of data quality across Europe. And we came up with a declaration, which is on our website, but the declaration has more detail. These are the headings, and I just want to refer you the first one: develop and promote data quality standards and labeling. And I mentioned the European Health Data Space has included a stipulation that data sets in the future should be quality labeled. And we are optimistic of working with some of the other colleagues who were in that event at winning a European Commission proposal, we'll hear in a couple of months' time, to actually develop a standard data quality label for data sets that can then be used right across Europe. And we hope infecting the rest of you so that you all join forces and we end up with a planet-wide data quality label that is standardized in how it's generated and allows for more trustworthy understanding of fitness for purpose, which data can be used for life-critical decision-making, which ones are better more taken as broad directions of travel or hypothesis generation data sets. Trust has come up already in our discussion, and I just want to emphasize the fact that trust is a critical part of how we go forward. It's not only limited to the European health data space, the entire health data ecosystem has got to look after trust. And one of those is actually that the technology products are trustworthy. And so we've been working with others on a method of assessing ICT products to see whether their information governance, data protection, privacy protection, and security measures are adequate. And so we now offer that as a certificate that companies can have. It's just starting to gain interest, and we will be offering that certificate. And I also understand that the US is about to ramp up its interest in certifying electronic health record systems, but we mustn't limit it to those. There are a lot of other systems now that serve intermediary purposes, data brokers, data facilitators, bridging between care and research, lots of third-party products that must be trustworthy as well. And then I mentioned apps and wearables. As we move towards more and more data being collected by patients, we have another project already underway in Europe that is looking to promote an ISO technical specification 82304, which is a health and wellness apps assessment framework. And we are looking to turn that into a quality label that can be applied to apps and allows people who might use them, whether it's health professionals or patients or healthcare payers, health insurers who endorse the use of apps, to actually know which apps they can trust and give to their patients with confidence. That's the team working on that and the website for that. Now, I mentioned previously this spectrum of opportunity, and I want to emphasize something that actually already has come up in the discussions, so I'll be fairly quick. But when it comes to the reuses of data for research, especially as you move towards the right-hand side of the spectrum I presented you earlier, the public understandably find it hard to trust because they don't always understand how data are used and why. The people who might be using the data are unfamiliar actors. I mean, for example, I was quite taken aback over a decade ago to hear about how McLaren, the Formula One racing car company, was working closely on intensive care data analysis. But they were, with very legitimate and valuable results, which I won't tell you about unless you ask me a question. We know that patients find it hard to trust when you go from left to right. And so it's really important that we work not only on the European health data space, but right across the planet if we can. Certainly in Europe, we're aiming to work on how can we build a trust between two forces that seem to be gaining grounds. On the one side, we have legislation on data protection that really safeguards the individual and if you like, locks the data into a very safeguarded and limited use space. But then on the other side, something that we have in Europe called the Data Governance Act, and the concept very powerfully understood in the US, but in other parts of the world too, called health record banks, which are about where people can put their data or authorize their data to be held by a trusted third party, and then give slightly broader permissions for their data to be reused. In other words, they can indicate categories of reuse that would allow them to feel that their data is being used, will avoid them being asked to give permission, 20 times a day, and yet at the same time, societal benefits arise. And my feeling is that we're only going to be able to achieve the balance between these two things if we really have a set of good practices in the middle that are universally applied. And I've listed them here. They're not really for easy discussion in a presentation of this length. This is, again, another presentation on its own. But I just want to say that we are busy working alongside many other players in Europe on what might be the content of these items, what would be good enough to give an assurance that is strong enough that the public feel confident about the uses of their data. And again, in the interest of time, I'll skip that slide and just come to my closing slide, Chuck, which is to say that if you found some of the things I'm saying in this talk interesting, on our website, we have a number of reports that you can access. They're just available on the URL. The ones at the top are consultations that we ran with others in a project, looking at the European health data space before the regulation was published, when it was a slightly looser concept. We engaged with industry, we engaged with patients and public sector and societal groups, and we engaged with sort of multi-stakeholders to say, what would a good European health data space look like? Why would you like it? Why would you use it? Why would you value it? What would make you trust it? And then on the bottom row is a set of more deep dive multi-stakeholder consultations we've run on different aspects of the health data ecosystem, dealing with things like data quality, trust, interoperability, digital literacy, and so on. So it's a busy space, but if you want to get a purchase on what is happening in Europe, this is one place where you can go and download a few PDFs and scan them. And I'll stop there, Chuck, and say I think I've really talked for too long. Can I stop sharing now and actually move into a universe where I can see a few more faces, which I can? Yes.
Yeah, absolutely. And let me pose a question that was posted earlier, and we just did not have time to get to it at that time. But this question goes to, when data is expected to come from diverse sources, what are some of the examples of standardization protocols that could ensure consistency in quality of data being collected?
Consistency of data being shared maybe rather than collected. If it's collected in heterogeneous systems, that's how it is. That's how it's born. It's born in multiple formats, but then it needs to come into a more harmonized state.
I think that's a fair interpretation.
There are a number of standards that are existing. I mean, if you were to go to ISO, for example, there's a standard that I've been very involved in, which is called the Electronic Health Record Communication Standard, which specifies information models and some semantics. Many people would nowadays turn to HL7 FHIR and say that the collection of resources that are growing are another way in which data can be fused. But both of those two are focusing on individual level data. And that is data that is really going from point to point or into an e-health platform or central repository to support the individual. It's a bit like the green zone on my circles of the EHDS. But there are also formats that are being used for building data warehouses and interlinking data warehouses where the purpose is analytics, not patient level use. And examples are the OMOP data model, the OMOP data model. The regulatory environment uses Sentinel as a data representation. And then another one is I2B2. So those are three strong examples of information architectures with models and semantics and architectural frameworks that allow you to bring data into a common point of reference for analytics purposes. So the standards exist. I think that none of them are perfect. And I'm sure each of those involved in making those standards doesn't feel they can retire and go away and stop working. But I would say there is so much already that's good that it is not appropriate to say, I'll wait till the standards are ready. Get going, roll up sleeves, start using the ones that are there. They're pretty good already.
Thank you, Dipak. Brian, you placed a question. I see Brian Martin still here. You placed a question about the business of medicine that we did not get to before. Do you want to just say that in your own words, since everybody's unmuted now?
Sure. So Dipak had asked if the EU was an outlier, and I would argue that the US is an outlier because we are so much more focused on the business of medicine, making money on it, extracting profits, and that conflicts with the care of the patient from the physician's perspective. So that was my comment. Thanks.
Well, it's interesting you should say that. I mean, a little bit of work that's been done in Europe on, let me call them kind of reporting data sets. So you would call them in the US claims data. Not all of the health systems in Europe operate on a claims reimbursement basis, but they still have to do reporting that is used for key performance indicators, rewards, promotions, and all sorts of other things. So you could say it's non-monetary reward, but it's still reward of some kind. And what we know is that when data is going to be submitted to an external agency, the mechanisms around coding, what is coded, what is not coded, you all know probably the term upcoding. Choosing, if a patient is sitting in a gray zone between two codes, you choose the code that has the higher reimbursement rate always as a matter of routine and so on. And when we see claims data being used in the US, a number of us who are familiar with that kind of research feel nervous. We feel nervous that the claims data is not necessarily reflective of the real patient and the real clinician work with that patient. But we don't see enough studies to validate and to clarify the differences between claims data. And the difficulty that I see is that claims data is very, very available. The only thing you have to do is buy it. So there's and organizations, especially industry that's doing a lot of research, has enough money to buy data. What they do not have is the time to painstakingly try to collect data from heterogeneous, real, close to the patient, close to the clinician sources. So they buy claims data and feel delighted with what they've got. And I'm nervous about what they've got. And I'd be interested, actually, Brian, you've kind of triggered me a bit, but I wonder really, on the US side, is there a nervousness that so much intelligence is being taken out of claims data, which might have biases?
So the nervousness is not as widespread as it should be. We have a number of investigations into something called Medicare Advantage fraud, which basically is a company upcoding records to garner higher payments from the Medicare program. And that's pretty rampant. The estimate is something under $60 billion a year in excess payments. So your caution is well justified.
Okay. So Brian, I'm going to tease you now. You said 60 billion, I think, or million, I think billion.
Billion, yeah.
You said. But that's not the metric that troubles me. I'd love to know instead how many patients have records in these databases that are misleading, because actually the numeric quantification in fiscal terms is one of the damages, sure, but the other damage is how much misleading insight generation is going on. I'm only teasing you. I'm not saying you but, you understand. I'm more worried about how we are, diverting medical knowledge in the wrong directions through biased data.
Yeah, as am I.
I know you well enough to know that you would be, Brian.
Okay, so we've we've asked all the questions that have been posted, and you have answered them very, very well, Dipak. So let me ask now, before we conclude the session, if anyone would like to pose another question or make a relevant comment. If so, please so state. Okay, so hearing none at that point, we really would like to thank you for attending. There's a post-event survey available at the QR code you have before you on the screen. I'll remind you that a link to the webinar materials will be on the Learning Health System Collaboratory archive page. For those of you who like to plan ahead, September 27th will be a very, very important day for the Collaboratory. We'll have our 2023-2024 kickoff event, which will be our annual poster session, showcasing all the Learning Health System, or much of the Learning Health System work that is going on at Michigan. As many of you know, we have about 28 member projects, and many of them will be presenting posters of their work. And there we may get some posters from projects that are not members of the Collaboratory. That sometimes happens, and we hope it does. So Dipak, thank you so much. This has just been a terrific presentation. It's really informative to know what is happening on the other side of the pond, and your command of that is probably unique. And the fact that we were able to learn from you about this is very much a privilege for us. So thank you. And
well, thank you, Chuck. And it is a privilege and honor to be able to address the Collaboratory, but also being ourselves as an institute learning and supporting learning health systems. You know, I don't feel an outsider here. I feel an insider here. And you know, as you know, we intend to work closely together in the coming years.
We're glad you feel that way and look forward to that. So thank you, everybody, and we'll formally end the webinar now.